Hello, this is Oleg Borisenko and Market Access Insider channel. In our programs, we discuss organization and financing of healthcare services and medical technologies in European countries. Today, we're in Milan, Italy, and we're going to talk to Luigi Mazzei from Edwards Lifesciences. We're going to cover a broad range of topics, including the general decision-making framework for introduction of novel technologies, the role and evidence requirements for health technology assessment, the history of TAVI in Italy, and the future challenges of the system. Hope you will enjoy the program. Luigi, thanks for joining us on this program.
Thank you.
Can we start with a general overview of decision-making framework for introduction of technologies at national, regional, hospital level in Italy?
Yes, actually, the three levels have some importance. First of all, because Italy is a federalistic state, so where regions have a big role in healthcare, especially in funding and planning. That's why it is the three level at national level for setting the framework is essential. The regional level is important for planning the resources, for funding and reimbursement, and for HTA. Italy has been historically country for regional HTA. At the same time, we do not forget the hospital level, the local level, because especially after the crisis of the 2008-2010, the economic financial crisis that impacted the healthcare systems, hospital budgets are essential, especially in the public market. We know Italian hospitals are mainly publicly owned and private hospitals that work with the public system. Especially for the public hospitals, it is essential to cover the budget level. And inside the budget, hospital managers have to keep under control the expenditure. That's why it is important for real access of new technologies to cover the three levels of the system of decision making at national level, at regional level, and the local level.
Mm-hmm. Who are the key stakeholders at these three levels?
Actually, if we look at the national level, of course, the objective there is to setting the framework and the political scene. Mm-hmm. That's why, of course, the main stakeholders are the Ministry of Health. At real political level, probably the healthcare commissions of the Senate and the Chamber are key stakeholders to involve. This is at political level. While at technical level, AGENAS, the Agency of Regional Healthcare Systems, and now the Istituto Superiore di Sanità, National Institutes of Health, recently evolved to be a more clear role or in decision making. These are the key stakeholders at national level, of course. If we move at regional level, here it depends region to region. Here the federalism impacts a lot the way the systems are organized. And region by region, it is essential, it is important to understand what are the key stakeholders, what is the organization. In some cases, you have or you used to have regional care agencies or HTA units that are more or less developed. In some other cases, it is the political level that plays a key role. And then, so it depends region by region to understand where are located the key stakeholders. At local level, at hospital level, of course, the first endorsement is the clinical KOL, mm-hmm. is to gain the clinical KOL. and to understand what are the clinical KOLs that are able to talk a different language with the administration. Sometimes it's not the best user, but rather the most, I would say, political skilled, that is able to open a dialogue with the local and sometimes also with the regional administration. Of course, at local level, again, it depends of the size of the hospitals, but the management of the hospitals, and in some cases also local HTA units, are important stakeholders to involve.
So you mentioned health technology assessment framework. So what's the significance of HTA framework in Italy?
You mean the national plan, the new national plan?
Yeah, we can start with that.
So there is it's been a long and sometimes never-ending debate about the role of HTA in Italy. Italy has been the cradle of hospital-based HTA, somewhat, meaning that there have been several experience of local hospital-based HTA units that raised in the last years. The regional level, the regional HTA have been strong, especially in some regions where the healthcare systems were more, say, evolved or more structured. The attempt that the Ministry of Health is doing recently, since 2016, is to implement a national plan for HTA. This is, in theory, could be a real good opportunity for looking for uniformity, equity of access, also to avoid duplication so resource-consuming and time-consuming duplication of evaluations. We as industry have been involved at the Tavolo dell'Innovazione, the innovation working group set by the Ministry of Health, together with the Cabina di Regia on HTA, that is the official organism created to implement this framework. The attempt is very interesting and very positive. We are still in a stale phase because we, as industry, together with many other stakeholders, we contributed to work on the operational documents of this new framework, new plan. We are still piloting this phase. We obviously hope we hope about an acceleration of the implementation of the plan, because my impression is that we are still in the middle of nowhere, while at national level we have a push for concentration, for coordination of the HTA. At the same time, regions are still doing more or less the same thing. The objective of the plan was to avoid duplication and integrate and coordinate the actions. We are still in the middle. And the point is that what I hope is that the Ministry of Health, the government, will put more effort to implement the national plan, meaning simply to put resources, economic resources, for the implementation of the plan. As of today, nobody knows what will be the cost of the plan, if there are resources for implementing the plan. And this is essential. This is essential because otherwise, I'm afraid that the plan may die in a while. And this could be a real shame for Italy that has been taken as an example recently on the way they are trying to approach the HTA at national level. So this is my impression. I hope that the national plan will be seriously implemented in a very short time.
And is the idea that the national process will be more or less the starting point for all regions to start assessment, or is it still possible that they would do their own assessments, or it will be all channeled through the national?
The idea behind the plan was to avoid regions to do their own HTA, especially on the technologies that will be selected as with the highest priority. And the more we go, if the national plan will be strengthened enough, at the end will be useless to do regional level HTA, especially for the most impacting technologies or the most impacting innovation. This is the aim of the plan, and from an industry perspective, I would be very in favor to have a national coordination, a national assessment in order to avoid the replication of regional HTAs. Still, the plan leaves the possibility of some region to do regional HTAs for technologies that are not selected, that are not prioritized. And this could be also a good opportunity because at the end, in terms of scarcity of resources, there will be just a panel of technology that can be assessed year over year. So the integration of the national plan and the regional activities can cover better the needs of the healthcare systems, because at the end, it is the need of the healthcare systems in general speaking. It is important that a real collaboration between the regional level and the national level will be established. A genuine collaboration, otherwise this will create some disruption in the two senses.
All right. So you mentioned, again, decision-making by actual payers and then advice and support by HTA. So what are the typical data or evidence they look into? For example, again, let's say regional health authorities or HTA organizations. Is it clinical or economic or both, and what kind of?
Here is there is still not a recipe for all. And in my experience, I would say I never had a clear idea of what are the expectations of some decision makers. Sometimes if you go with post-marketing follow-up data, they claim for randomized trials. When you go with randomized trials, they claim for real data. And when you go with real data, they complain because there are industry funded research. So out of the joke, it is very difficult to understand. Also because sometimes the requirements that you understand not clearly, not in a transparent way, sometimes do not apply with the real size of the epidemiological needs, with the real characteristics of the technologies, or with the real integration of the experience, of the user experience in the production of data. So I think that there are still a lot of clarity missing, clarity based on a fair and transparent and unbiased understanding and assessment of what decision makers can expect from a specific technologies and from what an industry that proposes innovation can propose for that at the moment of the launch of the technology. Let's not forget that it is essential to counterbalance, to find the right balance of waiting for having the right number from the studies and granting fast access for sometimes life-saving technologies that can start immediately saving life for patients that have no options or that are at risk with the current therapeutic options at that time. And sometimes this is not clear, this is not taken in consideration from the decision maker. They want to see the positive p-value and the right number, forgetting that in the meantime, this technology can save life anyway.
But if we can say again, in your experience, if we can say clinical evidence, organizational impact, and economics, what's out of these three has the highest importance?
Yeah, again, it depends on the type of technology. Of course, clinical evidence is the basis. The economic evidence sometimes is still perceived as, I would say, nice to have, but it is not really taken in real consideration when you evaluate the technology. I think also because when you do a cost-effectiveness analysis, or generally speaking, an economic analysis, the approach is to look at the full pathway of the patients, from the diagnosis to the therapy to the different therapeutic options, and on the follow-up. What we're experiencing now at hospital level, at regional level, is that budget allocation is done by silos. You have a silos for drugs, a silos for medical devices, a silos for personnel, and so on. It is really challenging, difficult to have a clear understanding of the pathway if you have to take in consideration all the caps and all the silos that you have to come across. This is crucial, in my opinion. While silos budgeting has been a good option, in theory, to control, to put under constraints, I don't want to say under control, under constraints, the healthcare expenditure, we are completely missing the real cost of the patient, the real cost of the pathway, which is the approach that, in my opinion, can give the real value to the healthcare. The objective of an healthcare system is not to take to cut the expenses or to have a financial control, but to give value to the healthcare, to give healthcare services, and to provide the best outcomes and the best value to the population. Economic analysis, economic evidence will be challenged until we don't change the mindset from a silos mentality to a pathway mentality. We can say the same for the organizational impact, for the organizational aspect. It is, while this is a crucial factor, especially for technologies, for medical technologies, it has been often disregarded by decision makers and as a consequence by industry to investing in studies that demonstrate this. Again, here there is a big room for improvement because the objective is to optimize the process, optimize the pathways, and then evaluate the cost under different perspectives.
All right. So, in general, in most of the European countries, reimbursement activities are done more or less by clinical, hospital stakeholders or authorities, but not by the industry. So what is the formal role of industry in reimbursement processes in Italy?
Industry doesn't have an official role. That's the problem. Industry in this sense is not perceived probably as a stakeholder. It's perceived as an informal or indirect stakeholder. We had very good experience in some cases. We have been involved by the Ministry of Health with our industry representative in several working groups, but there is still the need to define a clear and transparent pathway and the processes for a direct dialogue between industry and the healthcare system. This is another area where I think that the clarity can bring value to all the stakeholders. Clarity and transparency in the relationships can bring value to local and regional decision makers and to industry. Of course, the problems that we can experience in the relationships between industry and decision makers, especially when we talk about also tenders or public procurement, can create some perceived conflict and perceived conflict of interest. But I think that we have to find a way for, and would be good to have a clear space for industry to present their technology, to open a dialogue with decision makers, because differently from drugs, from pharma, when a medical technology, when a medical device enters into the market, there is still a lot to learn, and we can open a dialogue on understanding what are the key targets, the key objectives to focus on. It's a long time we are talking about managed entry schemes, coverage with evidence development, risk-sharing approach. I think that many companies are ready to open a dialogue on these topics with regional decision makers. Are they ready to engage with industry? I don't know. I'm not challenging their capacity to do it, but probably the rules of a dialogue for an industry are still too strict to open the dialogue and to make some pilot in this direction. And I think we have to face this issue in the future.
Yeah, exactly. There are some examples in Europe, for example, in France, where there are government-sponsored experiments where industry could be part of the, again, application group, so on and so forth, to study new payment mechanisms or new forms of delivery of care, etc. Exactly. So such practices could be brought on. Can we discuss some specifics of implementation of technologies? Edwards Lifesciences is one of the global leaders in TAVI field. So could you please explain a little bit the history of TAVI in Italy? So how technology was introduced? What was the pathway?
Yeah. TAVI has been, in Italy, has been launched early 2008. with the first experience, with the first products. And at that time, it was funny because I was joining at the time Edwards in a market access position, and it was really funny and easy because instead of being me proposing the technologies, many decision makers were understanding that they were facing a real breakthrough technology, so they were calling me. So they were facilitating the work. The point is that we faced, especially at the initial stage, the real problems of the regionalization of the systems. So the activity at that time was to go region by region to explain why TAVI was a breakthrough technology, why the perceived costs were completely different from surgery, because again, looking at the silos, you have the cost of the device that are completely different, while you have to help them to change the mindset and look at the process. So what we achieved at that time were moving region by region, were to create some experiences of good practices, especially in giving guidelines to the centers that were going to introduce the technology, and with some very good example, probably maybe the biggest success has been in Emilia-Romagna region, where at the time we were able to collaborate with the region for the first experience of coverage with evidence development in Italy, with the region that funded a data collection, clinical and economic data collection, in order linked to special funding in a limited number of hospitals. And that experience has been essential, has been crucial in Italy to change the mindset, to change the approach to TAVI, in my opinion. Then Italy usually is one of the first countries to adopt the technology, to introduce the technology. The problem is to expand the volumes up to the real epidemiological needs. And the problem is still there because the number of TAVI, while growing, are still well below the estimated epidemiological need, despite new studies, new clinical trial. Recently, the pivotal clinical trials on the low risk demonstrated in some cases also the superiority of TAVI in selected categories of patients. The story of Edwards the story of TAVI, in Italy, is a story that in the 10 years showed, unfortunately, a lack of equity of access. Mm-hmm. We have regions that are closer to the real epidemiological needs, while regions that were for a long time still behind are still behind, I would say, the minimum acceptable thresholds. And I think this is the key point of TAVI, of the adoption of TAVI in Italy. Mm-hmm. Despite the fact that in terms of clinical outcomes, we must admit, we must recognize that we have really first level of quality centers in Italy that can easily compete with the best centers in Europe. And this is a shame, because we are still not able to guarantee an equity of access to the whole country.
What were the payment mechanisms that were created in relation to TAVI at regional level? For example, was there any add-on reimbursement or DRG split? And
it's been a long story on this, with some good experiences, and again, the differences across the regions are really clear and evident. We had some regions like Lombardy or Sicily for a couple of years that recognized an add-on payment on top of a DRG. Lombardy is a different case in reality. Emilia-Romagna, after the pathway after the coverage for evidence in the coverage and evidence development that they did, they created a specific ad hoc reimbursement with a higher tariff with respect to the normal surgical DRG. Other regions, they continue to use the normal surgical DRG. The point is that, coming back to the beginning of the discussion, at the end, the level of the DRG is not a real issue, because the real issue is the budget, the allocation of the budget, especially for public hospitals. The meaning of the DRG tariff evolved and changed during the last year in Italy. While at the beginning was perceived really as a payment system, now we can define, roughly speaking, as an accounting system, an accounting number rather than a real funding. It is important in the budget of the hospitals, in the budget of the hospital, to find the right spot, the right place, the right space for this type of technologies. And there we have seen public hospital that increased with a steady and constant increase of numbers. Taking in consideration that the National Health Fund and the medical device budget is stable since 10 years. So this is a big achievement from my point of view. The growth of TAVI at having a stable, if not decreasing, budget available.
You touched upon a very important topic of having more or less the same budget to cover multiple technologies, not even speaking about medical devices, but let's say only interventional cardiology space. So initially TAVI was the first percutaneous technology, right, to offer that kind of access and to treat previously inoperable patients. But right now, there are many other technologies on mitral, triguspidal, again, some other technologies. And obviously, it is a problem of priority setting, right? Which patients to treat. Are there any signals that you see from the clinical community or from hospitals on what are the potential rules of the game, or again, rules of priority setting in this regard? Is it driven by the demand, for example, it's just the patients' demand that we have, or any other factors?
Really difficult to give an answer to this question. For sure, this is the challenge of the future. We are in a phase where, as you said, we have, after the launch of TAVI, we are still at the beginning of another wave of transformational technologies and life-saving treatments that will deserve in a couple of years or maybe months, again, the right space in the tight budgets of the hospital. This, I still don't see, I don't have a perception that decision makers at local level, at regional level, are facing this problem with, I can say, a propositive approach, with a proactive approach. And this will be a challenge. Also because we are talking about diseases, the valvular diseases that have been often not perceived for the severity they bring. Simply speaking, if we look at the mortality rates of aortic stenosis, not treated aortic stenosis in 5 years, they are similar to the most aggressive cancers. Okay, but there are still a lack of perception of the severity and of the mortality and the danger of this type of diseases. So we will face a problem of, we, industry, but we as a system, we will face a problem of having life-saving treatment in the cardiology field, having the same resources. So the point is, are these resources enough to cover the healthcare needs of an aging population, a population that will get older, that has the right to ask for more quality of life? I'm afraid this will be the real challenge. The economy and the global economy and the country economy probably doesn't help at the moment to increase the healthcare funds. But therefore, I think we need to find a way to looking at the healthcare and social expenditure in a different way, and there find real resources for innovation and for effective and appropriate use of innovation. But if I have to tell you, coming back to your question, today, is the system aware and ready to face this new wave? I doubt. We're talking about horizon scanning. We talk a lot about horizon scanning. I still don't see a real horizon scanning. So real looking at what will come in the future and what will be the impact of the future. As of today, horizon scanning is limited to have a short reports that says that we do not have enough evidence on this technology, and period. So I think that we have to work on this.
Excellent. Well, thank you very much, Luigi. That was a very insightful interview.
Thank you. Thank you. You're welcome.